everyone. Hello and welcome to aidsmapLIVE, NAM's Facebook Live panel discussion about the most important issues to come out of the AIDS 2018 conference. My name's Susan Cole and I'm here with an amazing panel. Today I'd like to introduce to you. First of all, we have Mercy Englube. She is an award-winning HIV youth activist and co-chair of the Sophia Forum, the women's HIV charity. Next we have Matthew Hudson, the Chief Executive of NAM and the winner of the Social CEO Award. Wow. When is there going to be a new one, Matthew?
Next week.
So you still have the title. You're safe. Michelle Ross, the founder of Clinic Q and director with Innovative Response globally for trans women and HIV. She's also a trustee of the Sophia Forum and has over 13 years experience as a psychotherapist involved in HIV. Over to Angelina Nibiba. I did ask her initially for a sentence or two and she gave me a full paragraph of information about herself, so I have cut it down a little bit.
That's absolutely fine.
She is the Associate Project Manager of the Salamander Trust, a patron of NIVNA, and has been working in the HIV sector for over 16 years. She's particularly passionate about the rights of women with HIV. Next we have Dr. Laura Waters, who arrived literally 20 seconds before we went live. Laura is an HIV doctor at the Mortimer Market Centre, Beaver Secretary and Chair of the Beaver Guidelines and a trustee of THT. And finally we have Greg Owen, who I think has more fabulous shoes than I do, so I'm feeling a little bit jealous. Greg is the co-founder of I Want PrEP Now. He is one of Europe's most prominent PrEP advocates, and he's also been voted as one of the world's 100th most eligible gay bachelors. So
Actually, I'm number 34.
Oh, so we should have said in the top 50, but anyway. So I'll be asking the panel some questions that people have sent us ahead of the event, but you people on Facebook Live, do feel free to message us as we go along and we will endeavour to answer your questions. And we also have a fabulous studio audience who I think will be chomping at the bit to be asking questions as well. So thank you all so much for joining us. So the first question I am going to direct at you, Matthew. The U equals U message is now a global movement and is of huge importance to people living with HIV around the world. Did you learn anything new about U equals U at the conference that you didn't actually know before?
Well, I don't know if you'd say that you learned anything new. I think what was really exciting about the conference this year was it was the year that U equals U kind of went from being kind of the fringe activist thing to being really accepted by everyone at the conference, certainly by the kind of scientists and by the researchers and the people, the medical authorities. Of course, we did get new data, which was the Partner 2 study, which is the second part of the Partner study, and that's the third, fourth major study where they've really looked for cases of HIV transmission from someone who's undetectable on treatment. And it's the fourth time, 0 cases. And now we're just really confident that actually 0 cases means 0 risk. So that was really exciting. And I think for me, that was the kind of the central thing of the whole conference.
Fantastic. And do we think that we're reaching all communities effectively with the U equals U message? And I'd like to ask Angelina and Michelle in relation to that. What can we do to improve how we're getting the message across?
I think I'm just going to sidestep that a little bit and just reiterate the fact that for me what was quite clear was the fact that now we know it's U equals U is such a game changer, right? And it means so many things for so many different people. For some people it means being able to love without fear. For some people, it means being able to realize the dreams of starting a family if that's what they want. And for others, it's probably just going to make that conversation about telling your significant other or your partner about your status a little bit easier, right? So for many people, it's going to mean peace of mind, and which is it's a shame that it's not really reaching out to all the communities that it needs to reach. For me, I feel some of the things that need to happen, I'll just mention 3 because there's lots of things we could do. And I know we don't have the time today, but I think the first thing is we need to get the message out beyond the HIV community. We need to get it also to the people who are not living with HIV as well as ourselves. But also one of the other things that needs to happen is I feel that clinicians need to be giving the U equals U message to all patients. And the reason I say that is because we know for a fact that some clinicians do cherry pick, and I'm not saying you, Laura, but I know that there are clinicians who are cherry picking the patients that they give that message to because they'll think, oh, maybe she's not very adherent to her treatment, so I'm not going to tell her. And I feel that that's really patronizing. Patients need to have that information so they can make an informed choice. And perhaps for that patient who is not adherent, maybe the U equals U message, maybe just a little spark that they need to actually change the way that they think and be adherent. The third thing that I think needs to happen really is it's important that the messaging around U equals U changes in a way that is inclusive. And by that I mean that if we look at the way it is at the moment, it's great, but there's a huge focus on undetectable. So it needs to be inclusive in the fact that it should also include people who are not going to attain undetectability, because there are a few people who won't. And so it's important for them not to feel marginalized. So it's really important that first and foremost, the message is not just about you can't pass it on to your partner, but actually you live well first and foremost. You can make informed choices, and then you cannot pass it on to your partner or to your unborn child.
Thank you.
Yeah. Absolutely, I agree with what you just said, and what Matthew said about the global message around UEQG is really important. It's so important that it does need to reach all communities globally, and yet there are so many issues globally. As the IOGT, we work with internationally. It's a group of we're a not-for-profit organisation. Our headquarters in San Francisco, and we work with trans women who are directors of the IOGT globally in India, Africa, San Francisco, all over the world, Bangkok, all over the world really. And we know for a fact that usually EQU has got complex issues for trans people as well, and around the concerns around reducing the viral load. That means you have to take treatment for that, and the concern internationally as well as in the UK for some, not all, for some trans people, is how will this impact on my hormones? Will it impact on my hormones? And does my clinician know enough about that? And there was a lot of discussions around these with trans people in the Global Village and in the pre-conference that we had on the Saturday, the trans conference. So there wasn't a clear view on it, but we know that in many countries trans people can't access treatments.
Right.
They can't access possibly hormones in some ways, and it's illegal to be trans in some countries. So having HIV, not being able to get the hormones, maybe unless it's off what we call the black market over the internet, and then not having treatments so easy because some trans people in some countries are discriminated because they're trans and don't get the treatments to reduce HIV levels.
I think for me, one of the things which I find most exciting about the whole U equals U message, I mean, obviously it has that enormous capacity to challenge the stigma that people living with HIV face, but also it's such a clarion call that we should insist as a basic right for every person living with HIV, no matter where they are in the world, that they should have access to treatment, that they should have support to be adherent to treatment, they should be empowered and informed. And this isn't just about improving the health of people with HIV, it's a public health response. This is how we end this. And that's what's so exciting about it.
Absolutely. Thank you.
I keep on butting.
I'd like to move on to you, Mercy. I understand the voice of young people living with HIV was rightly really important at the conference. I heard from a few people that you speaking in the opening session was the absolute highlight for them. So thank you so much for that. What do you think were the main issues for young people living with HIV at the conference?
I think it was about being heard, and so often was said at the conference, oh, we've got more young people here than ever before. But I think really it's about knowing that you have a platform, but also the right to make choices and decisions without having to sort of get a tick box from everybody else to say, oh yeah, of course we can approve that. And so I think AIDS 2018 was really good for galvanizing young people to understand that actually when we come together we do have a power. And I had the chance to meet UNICEF's chief exec, and really we really challenged her on how many youth advisors they have, and they've gone on to make a youth panel. And I think it's just instances like that that show us that AIDS 2018 really was a place where young people could come together and get a bit more power.
Okay, brilliant. I know that we've got some youth activists in the audience. Is there anything that James or Becky would like to add? Would you like to introduce yourself?
Hi, I'm James. I coordinate the Youth Stop AIDS campaign, and I had the absolute privilege to attend the AIDS 2018 conference as well, alongside Becky here and lots of different youth advocates coming across from the UK. I completely agree with what you said there, Mercy. It's great we finally had that platform to be heard and influence decisions, what's been done, or more about what happens next following on from the conference. They saw the power of young people, but now they need to work with us to ensure that young people are heard at every stage of project implementation, and also work with us leaders to implement that as well. So look at the epidemic now, we're going to see young people at the forefront of the next epidemic. We're the biggest generation of young people worldwide, and also the hardest hit by HIV. So I think we have the fundamental right, skills and leadership to be at the forefront of the epidemic. Some people are afraid of what might HIV be for the next generation of young people, but I think with our skills we can really turn the tide of the epidemic and be used and seen as partners as well. But I'm not sure if anything to add on that. Thank you.
That was amazing, James. Just to add on that I found being at AIDS 2018 motivated me to carry on my activism, and also it brought I met so many young people from all over the world, and they talked to me about like their challenges in their countries, but also the successes in their countries. And we discussed like what could the UK do more with young people, and also how can we carry on our message and also still have our motivation and our drive to campaign harder, to let people know that we do have our voices and we are prepared to use them. So yeah.
Okay, brilliant. Thank you.
I thought one of the things I thought was really exciting actually about, that there were a lot of young people, and what I heard really loudly was don't just include young people, employ young people.
Yeah. I'm not doing unpaid work in 2019 because of this. Because there's this whole drive. Sorry. There's this whole drive to engage young people. But why should I take a day out of my university or my work to do something that adds value to your organisation and get absolutely nothing out of it other than exposure, which I can't eat for breakfast?
Yes, absolutely.
To follow up on some of the young issues, the IGT were funded with VIVE to reach out to young trans people, young leaders for the future, so future thinking, and that's really important to engage younger trans people. And we were able to we reached out to 10 trans people globally, and only 8 were able to come. 2 didn't get a visa to come into Amsterdam, and there were 2 people living with HIV. So it was really important that they had the opportunity. They got a lot out of it, and I think it was an opportunity that needs to be repeated in the future.
Fantastic, thank you. Now I've got a bit of a medical question here, so I'll initially direct it to the doctor. There was a lot of attention about a drug called dolutegravir, both encouraging data as well as concerns about birth defects. So what's the deal with this, Laura?
So dolutegravir is one of the relatively new drugs that we use in combination to treat people living with HIV, and it's been shown to be highly effective. It has relatively few interactions with other medications. It's pretty well tolerated. it's kind of ideal, and because of that it's featuring in the preferred treatment options for all of the major guidelines, including the World Health Organization now, and it works in resistant virus for some people, it works first line, it's a good drug. The issue that emerged is a concern over safety in pregnancy, and this is a really challenging issue because actually no HIV drug is licensed in pregnancy, apart from an old drug called zidovudine or AZT, which is licensed in the later part of pregnancy, because you can't really do safety studies. You can't ethically take hundreds of pregnant women and expose them to drugs. So you have to rely either on kind of animal studies, very early studies in drug development for safety signals, but later on it's all about what happens after the drug's been licensed and after it's been rolled out. So you have to collect reports on safety. Now there's a cohort, a big group of several clinics in Botswana where they've been using dolutegravir first line in women, and they've followed up very carefully, very detailed reports, and if there are any birth defects, and birth defects do happen, but they collect all the information, they're verified, and what this group showed was a higher than expected rate of birth defects in women exposed to dolutegravir in pregnancy. Now the numbers are tiny, these are 4 defects in over 400 women, but the pattern is they're all what we call neural tube defects. These are defects to do with the development of the brain and the spinal cord, so they can be quite serious. And it's a really difficult balance. If you ask a statistician, they would say it was really too early to know if that signal was going to be significant or not. Because if you look at groups of people that are too small, a small number of events can seem significant. However, it's so serious that you can't really keep that information to yourself. So what happened is the information was released. There was frankly probably quite a lot of panic and quite a lot of rash decision making. I think with hindsight, if everyone had got together and planned the response a bit more cohesively, it would have been better, but it led to some countries saying, right, women can't have dolutegravir first line unless you prove you're on a long-acting method of contraception. And there was a huge pushback, quite rightly, from the community at the Amsterdam conference saying, hang on, this drug's a good drug. I want an informed choice. I don't want to be told what I can and can't take. I certainly don't want guidelines telling me I have to be on long-acting contraception if I live in a country where I can't even get regular access to that contraception. So it's still rolling out, more cases being collected. The next data release will be in March next year, but already they've released some information informally that signal's already gone down, that the risk doesn't appear to be as high as it was earlier this year, and I suspect with longer follow-up then we'll see it is as safe in pregnancy as other drugs, but we need to get more data first.
Okay, brilliant. Does anyone have anything to add in relation to that?
I think it's just reiterating what Laura was saying. I was speaking to one of the young ladies who was actually on the march demanding their rights. And I said, what are the women saying, the young women saying? And she said, actually, exactly just that. What the women are saying is they want the information to make the informed choice, because actually when you just say you're pushing them off, it's being a little patronizing, isn't it? They can make a decision like anything else, like any drug that you're taking. If you're given what the potential risks are, we can make our own choices. So they just want the information to be given to them, but also what they want is, as you're saying in the earlier on, there was a bit of a, I wouldn't call it a hoo-ha, but it was actually quite, demoralizing, the information that came out. But women want lots more messaging, making that, kind of lowering that, that, what do you call it, panic and, that information. They want that to actually be reduced now. Okay. And they just want bodies like WHO to now make sure that, just as they were very active in terms of making sure that women were not being given the drug, that actually women do have access. Okay. They want the access.
Brilliant, thank you. I'm going to ask a question about PrEP, and then I'm going to open it to the Facebook audience and the wider audience. So Greg, in the fabulous shoes, over to you. PrEP has been an absolute game changer, and I think we can all agree that you played a really important role with that. So thank you very much, Greg. So what's the latest that's come out about PrEP from the conference and since then?
Well, I don't think we learned anything particularly new from the conference AIDS 2018. There was some interesting kind of top-line preliminary stuff come out from Jean-Michel about on-demand PrEP, which is taking pre-exposure prophylaxis just before, during and slightly after a planned sexual encounter, that's just as effective for anal sex. So that would
predominantly be men who have sex with men. So it's just as effective as daily. So we know from the PROUD study, it reduced infections in that group of people by 86%. The original EPRGAY also reduced infections by 86%. The interesting thing with EPRGAY, when you look at bless you. When you look at the EPRGAY open label extension, infections in that group reduced by 97%. So we're starting to see now in this new, it's very, like 7 months follow-up is the median amount of follow-up that they have in the, it's a French word, it's prévenu study, and thank you. And so it's predominantly men who have sex with men again, which what we're finding is it's about 50-50 split in on-demand and daily PrEP, and there have been no infections so far in either group. And actually, just to add to that, worldwide, since they started trialling PrEP, there have been no infections in any trial or study cohort. For the caveat though, and it's always the important bit, in people who took PrEP as instructed. It's just important to say that.
Okay,
so,
fantastic. I'm a trustee of the Sophia Forum, like two of the panellists here. And we've been doing quite a lot of work in relation to PrEP for women. Does anyone have anything to add in relation to how we're going to get the message across that PrEP is effective for everyone, and, you know, what are we doing wrong?
Oh, in terms of what we're doing wrong, I wish I knew.
Yeah.
But I think it's just about sitting down and having conversations. We did a workshop sort of in the women's networking zone where we had a really good, frank and open, honest discussion with women about PrEP. And that's the thing, a lot of people are just sort of scratching their heads thinking, how do we roll this out? And so I think really we just need to dig a bit deeper and understand how better we can equip women to make the decision to whether they want to take PrEP or not, and make that available to them.
Yeah, I like that term, available. So make it available in different environments, because not all women go to clinics in central London or go to clinics in certain areas or in central towns, wherever they might live. So making it wider available in local areas, that means women can access it as when they need it. So I know there's another trustee, so Sophie.
We're two trustees. Who's done this? Yes, no, absolutely. See, I was going to turn to the other trustees of the Sophia Forum. Is there anything that you have to add about PrEP for women?
I'm Sophie, I'm co-chair of the Sophia Forum. So I think it's been quite a slow process, but there are a lot more people who are now more open to the fact that PrEP can be available and effective for women. And I would just ask that people build on the conversations that are already taking place. I know that a lot of clinics are now having conversations. I would encourage anybody that's listening who's from a clinical environment to be having these conversations with women. It may not be that they're eligible for the impact trial, but it's about informing them about another prevention method that is available to them. Just, you know, in your community spaces, start talking about PrEP for women, because it is, you know, it works for women as much as it can work for any other gender.
Does anyone else have any other comments about PrEP? Yes, I'm sure.
I echo all of that. I think some of the key things though about women are that the very early trials, some of the early trials in women in Africa didn't show any effectiveness, and it turned out to be because women just weren't taking the PrEP. And a lot of that was driven by the fact that when people don't know something's going to work, they may not take it very well. And we've seen the same in the MSM trials, that people took, I mean, EPRGAY is a great example, because open label extension, when people knew it worked, the effectiveness went up to 97%. But what we saw at the Amsterdam conference, there's a presentation that showed that the fewer pills you take, the less well PrEP works, but much more dramatically for women. So if women are only taking 4 pills a week, the effectiveness drops off in a way that it doesn't for men. And Michelle, you're absolutely right. It's about making it available outside of traditional sexual health settings, general practice, combining it with visits for contraception, all that kind of thing. But I think some of the new ways of delivering PrEP are going to be particularly important for women. Vaginal rings that could be combined with contraception, injectables. I mean, injectables are something that's discreet, doesn't require taking something every day. And there are some big PrEP studies looking at injectables and other delivery methods in women that will hopefully address some of these issues.
There was a session that I went to, which I thought, I mean, for me, it was like really fascinating. It was about, what's working. And they had presentations from New York and from Sydney and from London, where we have seen, in all of those three cities, we've seen some quite dramatic drops in HIV diagnoses. And what that comes out of is increased testing and people therefore accessing treatment. So U equals U. That's obviously had a huge impact. Government support. That was key to all the cities where we've seen success. It's where the local government has really got on board and pushed and supported and worked with community to ensure that all of the buttons are being pressed. And obviously the other one is PrEP. And that has had a huge impact, as we've seen in London, as we've seen in New York, as we've seen in Sydney. Especially, actually, new data has since come out about Sydney, which is phenomenal. But in all of those cities, the really dramatic drops are amongst gay men, amongst cis gay men, and more amongst white gay men than amongst BME gay men, and more amongst men over 30, possibly over 40, than amongst younger gay men. So, I mean, every time you hear this great news, and I think for me what it says is the capacity of the tools that we now have to prevent HIV is so great. We've seen its success. How do we ensure that it reaches everybody?
I think what we're seeing with PrEP
is a further and extended highlighting of the inequities that have existed for generations, certainly decades, within HIV and HIV prevention. So I have two things to say on PrEP just while we're on air. There are still, because this is what you can do for PrEP for women and people who are not gay men, there are still ring fence places. A lot of trial spaces are full to men who have sex with men, so that's gay and bisexual men, but there are still some ring fence spaces for women and other people. So it's the first thing. Also, I think a really, really key important thing that we as gay men can do to help support PrEP for women is that we have a burden of responsibility to try and shape the narrative. So while certain publications and outlets like the Daily Mail, for example, and I will name and shame them, while they paint this as a gay men's lifestyle drug for gay men and they shouldn't be given it because our lifestyles are wrong and our sex is wrong and we're deviant and all of the plethora of other shaming connotations from that, while outlets and while people compound that narrative, the people who we're doing an injustice to most of all are women. So.
Do you have any questions, Facebook Live?
Yes, one question just came through from someone called Elaine, and she asks the panel, are PrEP injectables available yet?
No.
Okay.
No, they're not. So, no. There's still quite a lot of work to be done. There's some unanswered questions. I think we're looking at a couple of years realistically, and then how that translates into logistics and approval in individual countries. But they're well under study, but not for a little while yet.
Yeah, I just want to touch on some of the things that were happening in the Global Village in Amsterdam. At the IGT we had a packed programme of various workshops, and one of them was a workshop on PrEP that I was facilitating with people from San Francisco, Bangkok and Australia, with a number of different identities gender-wise. And similar issues around PrEP, wanting access to it, wanting informed access in terms of research and the impact of trans bodies and the combinations of our bodies that we might have, and the impact of hormones and PrEP. It was a really important issue, and it was one of the most attended workshop, or whatever you want to call it, sessions in the Global Village for the IOGT. And but there was a wanting PrEP as well, but informed, with an informed. And at Clinic Q, we have a huge amount of people accessing the impact trial. Over 80 people, and that might not seem a lot, but it is when you think outside of London. There's hardly any trans people accessing PrEP.
Are there any other questions, or anyone else have any comments?
Yes, there's some really interesting comments coming through, especially from Bakita here, who says he agrees with the whole panel, which is good. But she also... Bakita also says there needs to be a much more targeted approach for PrEP for women, alongside a destigmatising sexual agency. And it's probably a much larger problem of understanding and publicising women and HIV generally, since to be more visibility of our broad experiences.
Totally.
Yeah.
Thank you. Well said. So, over to the audience. Does anyone else have any questions for the panel? Yes, Paul.
Thanks. We haven't mentioned trans men. There was some discussion about PrEP and trans men.
What would you want to know about trans men? It's really important that we are inclusive of trans men, because, especially in at the AIDS 2018, there was quite a representation of trans men there, but not actually many opportunities for trans men to speak about or present on the issues for trans men. When you say trans men, are you talking in relation to PrEP or the wider issues?
Well, initially in relation to PrEP, I mean, by all means, everything else. I mean,
yeah. So, well, there can be complex issues there, but there's no interaction with testosterone and PrEP at all. No negative interaction. So that's really important for a lot of trans men to use. But it's recommended that trans men usually use it on a daily basis rather than event-based. Really.
Jude, have you got a question or a comment?
Yeah, I do have a question. I mean, thank you so much. My name is Jude Macaulay, and I work for an organization called House of Rainbow. I was also at the AIDS conference in Amsterdam in the summer. The dilemma with HIV sometimes is the disparity between the global north and the global south. So when you were talking earlier on about access to HIV treatment, the global access to HIV treatment can be challenging in countries in the global south in particular, where there are laws that actually criminalize sexual behavior and oppresses men who have sex with men. And also is stigma driven, so people don't want to test because there are laws that will criminalize them. Now, what are the strategies that we can employ from the panelists here to work with HIV activists or indeed countries that really want to move the goal forward for HIV treatment?
Great question, thank you.
Matthew should take that one.
Absolutely, it's a great question, and I guess particularly with the reports which have just been coming out of Tanzania this week, where people are being encouraged to tell on to their gay neighbours, their gay friends, and to report them to the police so they can be arrested. And you look at the massive problem that there is in terms of HIV incidents in Tanzania. I've been to the country, and it's such a beautiful country, and I had such an amazing time there, and it breaks my heart when I hear these stories, because I can't imagine anything worse. And then we know, absolutely, as you say, that in those countries where they criminalise homosexuality, it means that gay men or bisexual men and trans women and trans men have less access to treatment, they're less likely to test. If they, there's things, it's like really basic things. If you have a rectal STI, it can often go undiagnosed. It's very easy for it to go undiagnosed. It's very easy for it not to have any symptoms. It can facilitate HIV transmission. If you are not able to tell your healthcare provider that there's a possibility that you have a rectal STI, that is only going to increase the risk of you being involved in HIV transmission, either acquiring HIV or passing it on to your sexual partners. It's a huge challenge. I wish I had the answer. I guess what I always feel is that you have to work with local activists. I think it is a real danger. Often these laws are actually they are rooted in the colonial heritage. So it's. I think as a nation we bear that burden of guilt and shame for what we have inflicted upon other nations, and I think that the only thing that I feel is I want to say to local activists, what can I do to help? I don't want to make things worse, but I want to do what I can to support you. But there are some brilliant local activists, and also people like Busy, who's over here, and he is working to bring about change, and I think that's fantastic.
Fantastic.
Can I just add to that? So I was in Botswana in June, and we had the chance to meet with an MP and talk about the fact that Botswana might have a really good treatment program, but actually, if you're going to be criminalised for turning up, then really the politicians need to be open to engaging with the public and having conversations about that. And yeah, it's about getting local activists in when you have opportunities like that, because I know that we did, and you know, I hope that it was a fruitful conversation for that politician to then go and impact other politicians on how they can be innovative in their HIV response.
But it is so challenging. There are no magic answers, are there, when it comes to crazy despotic governments and the like. But I think what we can do is equip people with the right information and support, make sure they know that there are people around the world that completely support their messages. And I think it's about the publicity, because I think you've got to be really brave to stand up in some of these countries. And I think the more that we all work to make everyone aware of the challenges they're facing and where bad things happen, publicise them and hold people accountable and talk about it. Because so much of this is unknown to so many different people, and it's really, and there's so many, I mean, going back to U=U, Bruce Richmond, who was the kind of founder of U=U in the US, was telling me a story about a colleague of his in Africa who'd been promoting the U=U message. The American funder pulled their funding because they didn't agree with that message. And that's just outrageous.
I completely agree with everything you say there. We see such amazing things coming out from these groups working in the Global South, often with no funding at all. And that does reflect the current situation. Every year there's $7 billion missing if we're going to reach the 2030 targets of ending AIDS. And the groups that need the funding the most are often the ones being neglected the most from donors and from governments. So I'm pleased to see some countries, including the UK, taking a big step to step up and funding organisations like Robert Carr Funds that works to keep population groups and MSM who kind of working to change the system as well. But I think there needs a lot more work from all governments and all leaders and us here in the UK to call out our MPs to support HIV still and support the funding gap that's still there, especially with the Global Fund of Punishment coming up next year as well.
I didn't catch your name, I'm sorry, but can we come back to you? I don't know if you have any ideas about... Yeah, sorry.
Right. I mean, I do have ideas, and I think some of the ideas, I think Matthew mentioned one of them, is to actually work with local activists. And I think that, the danger is that when the Global North says something, then they want to dismiss it. But if it comes from the Global South, then it's actually more important. And I think that it's important to raise the issue locally and then develop it, empower the people on the ground. And I think Mercy gave a good example of listening to the MPs and the local people in Botswana. I mean, I just got back from Botswana myself, but actually I went for a wedding. So, yeah. But I think that the important thing is to work with local people and really hear their stories. What's even more challenging is my own native country, Nigeria, where they now have the HIV testing kit, which is a good thing. You will have thought so. But employers are using the HIV testing kit to test their employees for HIV and dismiss them if they come positive. So you can see it's a serious problem in Nigeria right now. And, it makes me really angry that, people are getting fired from their job. I mean, there's a guy who contacted our organization saying, I'm 32 years old, I'm an accountant, a qualified accountant. I've been to 4 job interviews, and every job interview included HIV testing, which is going to come back positive. So he wouldn't get the job, not because of his qualification, but because of his HIV status. And that's discriminatory in itself. So the question is, how do we challenge the Nigerian Health Service to say, employers need to stop this madness so that we can reach that goal? In Nigeria, people are not thinking about U=U. They're looking about how can they get a job. And now there are barriers because there's access to this instant testing kit that anyone can use. But I've made it clear to many of my colleagues that it's actually illegal, but until we challenge it, within the legal system, and then we get results, then we might be able to move forward.
Thank you very much, Jude. Does the audience have any questions, or is there anything else coming through from the Facebook Live audience?
No, I saw a lot of agreement with...
Yeah!
There was a question earlier as well from Paul Chettle, who asks, is there anything coming up from the conference on a cure for HIV?
it's, you know, everyone considers it the holy grail, and there are more and more and more small bits of research making tiny steps forward in terms of progress. But in terms of anything realistically hitting clinics anytime soon, everyone keeps saying 10 years away, 10 years, and I think it's still at least that away. I think the real challenges are, what's the definition of a cure? People can't agree on what you'd measure to determine if someone was cured or not. And another issue is you know, if cure is stopping your HIV treatment, how long do you keep following someone up for before you actually say, no, you're cured? Because in the U=U era, there will be some people who stop their treatment and the viral load will come back up. And how you manage that and how you deal with that, I think there's still a lot to learn. So there's lots of exciting science. There's quite a lot of investment in the cure drugs, which is really promising. But in terms of anything reaching clinics, we're a long way off yet.
Because there was a report, was the River trial, and you know, and there's a kind of quite a lot of hope around that. I mean, it kind of felt a bit exciting, and then, yeah, unfortunately, it just didn't work, and they're no longer pursuing that, I believe.
No, that's true. But with every failure, they learn a little bit more about which targets to go for and which mechanisms.
But there's some vaccine development stuff, which is quite interesting.
There is. You're moving into fields that I don't know so much about, but again, vaccines. The vaccines are are improving absolutely. And actually, there was a vaccine quite a few years ago that was 30-40% effective, which was considered not good enough by many standards in medicine. That would be considered pretty good, but.
I think part of the challenge for that is because PrEP is so effective now that actually everything is now being compared to PrEP.
Yeah, I mean, I just wanted to, because I get asked the cure question a lot as well, and it's a very valid question, but if we just take a little step back from what we're talking about, and I'll quote Linda Gale Becker, and these are her actual words, we have the tools we need to stop and end new HIV transmissions. We might not have what we want by way of a cure, but we have undetectable and untransmittable, and we have PrEP. What we lack is the political will and a global coherence.
I'll come over to Richard.
Hi, Richard Watkins from Bloomsbury Clinic. I'm a patient representative and I work for Terence Higgins Trust. I just wanted to pick up on what you're saying, Matthew, about the River trial, because I was a proud participant on the River study, and I was on the cohort that were given this new vaccine that was maybe going to find a potential functional cure for HIV. And we were a bit disappointed when the results came back as they were, but what the trial showed was just how effective antiretroviral medication was for someone newly diagnosed. In my arm, as well as the arm that wasn't given the vaccine and all the other things, HIV viral load fell as quickly in both arms thanks to antiretrovirals. So when we were given this feedback at AIDS 2018, it showed just how effective antiretroviral medication is and how quick U=U can become a reality for newly diagnosed patients, which was exciting.
Another question coming in from Sophie, and this question to you, Laura, whether you can talk more about new ARVs on the horizon and also evidence of weight gain for women, especially through dolutegravir and molnupiravir.
Yeah, so I'll do the weight one first. So this has been a signal that's been emerging mainly initially from patient reports describing weight gain on dolutegravir, but also raltegravir, which come from a family of drugs called integrase inhibitors. And then people have gone back and they've looked at groups of their patients, and they are observing this signal that if you switch to one of these drugs, you do seem to gain weight. You gain weight on a lot of drugs when you switch to and from them. And when you go back and look at a group of people that have already taken something, there can be all sorts of factors that affect weight gain. It's really difficult. So the best way to look at it is in controlled trials, where you take people and you randomly assign them to one treatment or the other. Whenever anyone starts treatment, there's this effect of return to health, so that it's considered it's normal to gain a bit of weight when you start treatment. Whether that's really true now, when people are starting treatment at good CD4 counts, not waiting for them to fall, I don't know. But in the randomised studies, there have been some signals, and in fact at the Glasgow conference, which just finished yesterday, a trial that I've been involved in, we presented some data showing significant weight gain on people switching from one particular drug onto dolutegravir. So there definitely is a signal, and we're going to see more and more data. There's some really big studies collecting weight as an endpoint. The fact we've not been reporting weight in a lot of the big studies, I think, is really poor, because it's basically free to measure. You do it at every trial visit anyway. And in fact, the FDA, who oversee all the regulation of drugs in the US, I understand are going to insist that weight is collected as an endpoint in these studies, because it's something that people report, that people are concerned about. So of course we should be collecting it better. For new drugs, I mean, there's a lot of new drugs in the pipeline and things in very early stages of development I won't mention, but in terms of things we're going to have very soon, there's another drug called bictegravir, which is from the same family as dolutegravir, which is going to be available in a 3-in-1 pill. It's licensed already and it's available in some parts of the world already. We're just waiting for that to happen in England. We've got other drugs from other classes that we're using that are all just going to add to the choice that we have. But the challenge is all drugs do pretty well. If you take them, your virus will be undetectable. And you're looking at smaller and smaller and smaller differences. And justifying new drugs, which tend to cost more money, for relatively tiny differences in a climate where the NHS doesn't have much money, and a lot of the older drugs are becoming available as generics, which are the unbranded forms, which are a lot cheaper. It's a really difficult balance, because you want to maintain choice, you want to make sure research and development keeps happening, but you also want to make sure we do the best that we can with our limited resources. So there's a lot to learn. So there's new things coming, more choices for people, but how quickly they get rolled out now, I think, is going to be more limited.
Thank you. So another
interesting question here from Elaine, who asks, how can we talk about the U equals U message to people who happen to live in countries where the ARVs stock outs?
I mean, recently, people were being given expired ARVs in Nigeria, in Liberia, in Uganda. It was all over the news, and it was scary that people were even saying that, look, I've just collected, the rest of my ARV for the next 2 months. After that, the uncertainty. And I think that, as we know, if people obviously have lapsed in taking their ARV, by the time they come back on it, there'll be resistance and things like that. And that's one of the things we try to watch out for as well. But I would also like to say a quick thing about the HIV cure. A lot of people are desperate, especially those who live in areas where, they're marginalized and they don't want people to know that they're HIV positive. So they're really desperate for cures. But unfortunately, I know that, people that are scrupulous are also taking advantage of it. So there are fraudulent claims that, some, person somewhere can cure HIV. And I think that the other danger is that, I sit here with a clergy collar on. I'm actually a clergy in the church. There's also a vast amount of claim within religious cures of HIV and healing. And that's where the danger is. So that people have been asked to throw away their ARV, for the sake of having faith that, God can do everything and anything. And I think that we need to be quite careful with this, because when it comes to HIV, I don't think that God is involved in this one if people are not taking their medication. No. Yeah, I believe that God is actually saying, take your medication. I think, the only prayer that they should be praying is that they find the right medication that works for them and keeps them alive.
I think you're absolutely right, and I think this is the challenge and the opportunity of U equals U, is we need to stop thinking of HIV treatment as a gift. We need to acknowledge it as a right, and that the lack of HIV treatment is a deprivation which we should not countenance in society at the moment. We have had the medication which effectively treats people, which allows them to live long, productive lives, allows them to have children who are born free of HIV, and also prevents them from passing on the virus. And it is disgusting that we are still talking about people dying of AIDS. Last year alone, the number equivalent to the population of Amsterdam, which is where the conference was held, died of AIDS. And that should not be where we're at right now.
Absolutely. I just wanted to add something to what Judy has said, which is really important. I was going to ask you a question, but you answered it. But I just wanted to say that, yes, there is, that's a big issue in terms of, some faith healers who are preaching the wrong message about people being healed and stopping to take their medication. But I think one thing we need to acknowledge is that faith is incredibly important to a lot of people living with HIV. And over the years, when I've worked with women, some of who have been going through the same situation, whereby they come and say, oh, my pastor said I shouldn't take medication because, I'm going to be healed or whatever. one of the ways I kind of found, because it's very easy to dismiss that and think that, you know, don't listen to the pastor, but actually that's not the right approach to take with somebody like that. It's actually about acknowledging that her faith is important. So what I used to do, and I'm not saying that everybody can do this, I learned to speak in their language. So I would say something like, you know, in the Bible, even when Jesus healed the blind man, he had to use, I think it was mud, correct me if I'm wrong. And so I say, well, you have to think about it like that. You don't have to make a choice between God and medication. So God works with the medication to keep you well. You can still have your faith, but you still need to take your medication. It's about acknowledging and learning to speak that language, because then they hear you. And not everybody can know all the verses in the Bible. Many years ago, the Mild May Clinic, you'll remember, they produced a wonderful leaflet, which I used to use and make reference to for people who are talking to me about stopping their medication. So what the leaflet said was, so I'd ask them, you know, if you want to go to the market to buy your groceries or do your shopping, do you stand at the bus stop and wait for God to deliver you to the market, or do you take the bus? So they'll go, I take the bus. I'm like, well, that's the medication. You need to take it to get you to where you need to go. And then they'll switch. But it's just about understanding. It takes a lot of patience. But once you do that, because then they hear that you're not just, you know, dismissing them. You're acknowledging it's important.
That's really important.
I've got another question coming through for Mercy. Mercy, they ask, what would you like to see improve for young people transitioning from pediatric to adult care?
So I'm working on a really exciting project, actually, on differentiated service delivery. And I think just that, the fact that young people need to be able to understand that they have a right to be able to shape their care to be what works for them, because otherwise the epidemic that we have amongst young people is not going to go away. And I've had some really exciting conversations with people, you know, who always say, oh, but when we first started out in this, we had none of the tools that you had, and I acknowledge that. But if we keep doing the same old, then we're not going to get anywhere. So I think it's actually about listening to young people and looking at people as individuals and not just key populations, and actually being tuned into that. I had a question, though. So you talked about political will, and I just was thinking about, obviously the next conference is going to be in the States. Do you think that AIDS conferences have the power to sort of change the political will of a place? Obviously, when we were in Amsterdam, people like Princess Mabel were very, very on board and supportive. What do you think is going to happen at the next conference? Do you think, you know, it has any power to impact on...
I have a question too, because is everybody, you know, in line with that, is everybody who needs to be at the conference going to be able to make it?
Oh, no. Yeah.
Oh, absolutely.
So I'm not so woke when it comes to this, and I don't have all the answers, and I'm not plugged into the current conversation that's happening around this. But I know from dipping in, just very lightly, that there's a lot of noise about this and a lot of pushback from global HIV activists. So Gus Carnes, and he'll be delighted hi Gus, we give him a mention because he's missing out. Gus made a very valid point that the epidemic should try where it can, not the epidemic, the conference and those global platforms should go as best they can to places that most need that attention, which is very valid. It's not particularly practical to be doing that all the time, but certainly the conversation has started already. Can those events change the political environment and the political atmosphere? I'm not sure, but I would prefer to see people do a little less but a little more regularly, rather than World AIDS Day. We're all crazy busy in December. I have 2 events a day, but I'd like to see people have that motivation, maybe a little less, but a little bit more evenly, because we live with HIV forever, not just 1 month a year. So.
The thing with the decision to host it in America, I understand why it's contentious, but it's been made now, and it's not going to change. There will have been huge amounts of investment and planning, so I think we need to accept it's where it is. There are things to learn from that region, because actually the San Francisco area, there's huge disparities in care, where some people do fantastically well and some don't. So actually I think holding a spotlight up and shaming the US, which is a country of huge extremes when it comes to HIV experience, huge. And actually those of us that can go, and I completely accept, of course everyone should be able to attend a conference, but it's not just the US where that's a problem, we know that. But those of us that can go, we go and we shout, because I think the American government are far more likely to listen to embarrassing protests on their own doorstep than us all going to a country where anyone can get in and going, no, 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 US, we didn't come to you. So I completely understand why people are angry, but let's go there, let's make ourselves heard, and let's make as much noise as we can while we're all in the US to try and improve some of what they do.
Can I just, sorry, we've only got 3 minutes, can I just take
One thing, with the IRGT, which is based in San Francisco, our headquarters there, we're already looking and we already know that many trans people will not be able to enter the US and not be able to go to San Francisco, not only because of financially, but because of the exclusions that are happening and the new things that are coming in from Trump and the administration there on the genitals assigned at birth means that's it for life. Yeah. Once that comes in, most trans people won't be able to get there. We're already looking at an alternative and having it in Mexico City. And so we're looking at ways that we can link up with the main conference, but it shouldn't have to be a separate thing.
Yeah. Absolutely. Can I go over to Esther?
Yeah, I just wanted to highlight what Greg and Laura was saying. So one of the statistics that came out of the CDC, so that's the Center for Disease Control in the US earlier this year, that is if you're a black man who sleeps with men, MSM, you have a 1 in 2 chance of getting HIV in the US. So, I mean, just like really highlighting the inequalities there in HIV.
Okay, brilliant. We've only got a couple more minutes to go. This has gone so quickly. I'd like to end with each panel member saying very briefly what the highlight was of the conference for you.
The highlight of my conference was to engage with new and upcoming PrEP activists who also champion the U equals U message, fill us in the audience. So for me, it was great to be able to be more inclusive.
Yeah, I mean, mine's the same. It's an opportunity to meet a huge breadth of people, and it's there are medical things discussed, but it's so much broader than medicine. And again, the vibrancy and the optimism was so inspiring. So yeah, engaging, communicating and sharing, I think, was my highlight.
Similar to that, but the voice and visibility of both women and young people, not as tokens, but actually as key players within the conference.
Yeah. 2 things briefly. One was our second conference, trans conference, the pre-trans conference on the Saturday before the main conference started, but also engaging with young trans people who would not have had the opportunity to be at such an event, and they were, and they're future leaders, and they're inspired by that.
I'm obviously, for me, it's got to be the U equals U message. I just think that we have lived with this burden of stigma of fear of our own bodies, fear of our own sexuality, fear of our own sexual desires for 30 years, and at last there's chinks in that armour, and that so excites me.
Mine's been just kind of looking back at the conference and seeing where people have stepped up and done what they said they were going to do as a result of the conference.
Fantastic. Well, thank you all so much. Thank you to the studio audience. Thank you for the Facebook Live audience. If anyone has any questions or would like to find out more, please go to the aidsmap website for more information. But thanks again, everyone. Thank you.